So now we move on to the next session. This is another change in the topic now. We have another speaker, who will be talking on optimized 2 and DP4 inhibitor FDC in type 2 diabetes management. I request Dr. Narsingh Mathur to please introduce Dr. Arvind Gupta. Dr. Narsingh Mathur, are you there?
सर वो ऑन करो कैमरा.
Okay, so Arvind is a person. He is from our city and he is known to all of us. Do we have Narsingh Mathur? Has he joined? Not yet. Okay.
Yes, sir, so he's trying to join, but
MD in general medicine, trained and having fellowship with various organizations. He is director and consultant physician, Jaipur Diabetes Research Center. He is an honorary consultant, clinical research, Bilal Institute of Biotechnology and Fortis Hospital, Jaipur. A medical referee and member of various organizations and won many national and international awards. He has more than 75 publications on national and international platforms, and he has been a part of large epidemiology done in Rajasthan, especially on hypertension, dyslipidemia, thyroid, and diabetes. So over to Dr. Arvind Gupta. Please go ahead with your topic on combination of SGLT2 and DPP4 inhibition.
Thank you, Vinava sir. Can I share my screen? Am I audible?
Yes, sir. Yes, sir, you're audible. Yeah, we can see your screen too.
How can I share? My screen is visible?
Yes, sir, your screen is visible and you are audible also. You have to open the PowerPoint presentation, sir.
Okay, okay.
So there is an orange arrow on the
Can I see
webinar. Now, now we can see your presentation also, sir.
Okay,
Just
okay. So
slideshow.
Yeah, this is okay.
Perfect.
Perfect. Okay. Thank you very much, Dr. Meenawat, and I congratulate Dr. Meenawat and his team for an excellent scientific program. You have put in a different conference, so it is not a different conference, it is a knowledge forum. And I like personally this term. This is a real knowledge forum you have put forward to all the clinicians. So let me start my topic. And what I have to speak in next 30 minutes or less than that, can we optimize two beautiful best drugs, SGLT2 inhibitors and DPP4 inhibitors in a fixed dose combination, and yet can we achieve the target HbA1c? Let us see. These are my disclaimers, but nothing for this particular presentation. Can I hide?
Yes, sir. The orange arrow. The orange arrow. You just click that orange arrow. The GoToWebinar control panel will be minimized.
Just a minute.
On the top on the left side, there's an orange arrow. Just click that, and the window will hide.
Just a minute. Can't see. Yeah. Yeah. Okay. So as we all know, the type 2 diabetes is a progressive disease. And if you see here, even right from pre-diabetes, if a patient is progressed to the diabetes, frank diabetes, and then in the post-diabetes era, if you see here, there are so many factors play a role in the progression of type 2 diabetes. We start from the genetics because we know that there are certain SNPs which are responsible for type 2 diabetes. We are yet to establish the real genetics behind the type 2 diabetes, but let us see, the first starts with the insulin resistance, the hyperinsulinemia. It starts with the weight gain, then dyslipidemia occurs, and there are maybe blood pressure increase, and then patient goes into initially impaired glucose tolerance, that is a postprandial glucose rise first, and then the impaired fasting glucose, that is means the fasting glucose also starts rising. And that is the point which is known as point of no return, means now the patient established the frank type 2 diabetes. And then we know the so many complications occurs. Starts with the microvascular complications, whether retinopathy, nephropathy, neuropathy, and all these things. But mind it, macrovascular complications starts right from the initially pre-diabetes era, 5 to 10 years before the frank diabetes. So despite multiple therapies, my dear friends, we are using so many combination of drugs, but majority of type 2 diabetes patients do not have the control. And this is not from India point of view. I'm talking of a global point of view. Even if you see here in the UKPDS, right at the start or diagnosis of type 2 diabetes, we know that most 50% of beta cell is already lost. And few studies say that not only the 50%, there are 60 to 70% beta cell are already lost as the when the patient comes to us for the first time. And that is our moral duty now to preserve these remaining 30-40% beta cells which is remaining in the type 2 diabetes patients. What do we have the current management? And if you see here, globally, only 26% patients have the glycosylated hemoglobin less than 9%. See the grim situation. And if you go for the Southeast Asia, it is 35%. So I think let us see what we are lacking. And that's why the evolving practice is totally different these days. We have to have the individualized goals. It is not mandatory that every person should have the 6.5 or 7% of the glycosylated hemoglobin. It depends on so many factors, how to individualize your patient's goal. Another thing is there are so many new and evolving global guidelines. And now previously we were centric only on the glucose. Now they are saying that no, okay, glucose is very, very important, but you have to go with the other management of lipids and the blood pressure and other factors. Not only that, previously after lifestyle modification, only metformin was the drug, and then you have to select the another drugs. But recent guidelines are changed together, and they say that no, you have to start with the drugs which can use or reduce the atherosclerotic cardiovascular disease. Anyway, initially, previously we were thinking, okay, start with the metformin and then go with the other combination of drugs. But recent evidence clearly suggests that you have to start the multiple agents right at the beginning or right at the diagnosis of diabetes. And what is our aim? Our aim is to treat to target, and it should not be a very slow stepwise approach. We should be aggressive right from the beginning, because as we have seen that only 20-30% beta cells are remaining in the type 2 diabetes patients at the onset of diabetes. So this is, I think, the most important cartoon we have to understand for the future management of type 2 diabetes. If you see here very clearly that what we are doing at present, that initially we are aggressive and then gradually we are actually lax and relaxed. And then this is what the graph is there, that we are relaxed at some point of time where the SbA1c reached around 7%, and then we relax and the patient goes on like this. So we are not aggressive. What should be the right approach? We should go even 7% or below 7%, and that HbA1c should remain for a longer period of time. So dear friends, what we are lacking here is a dysglycemic legacy. Means this is the point, this gap, what we are lacking here is the real reason for increasing micro and macrovascular complications in the diabetes, and what the patients get the most of the microvascular and macrovascular complications. So why the good glycemic control is very important. If you see here very clearly, this is the red and this is the blue one, and you see the poor control is the blue one, blue line, and here is the good control. What the thing is, if we are having a very good control of diabetes for his longer period of time, what we achieve? We achieve, of course, the cost is not very important. The cost also reduces, but the complications also reduces in the longer term of time. And that's why we not only reduces the cost of the therapy, but also expect the good quality of life in the future. Let us see this garden variety of patient, 49 years male, blood pressure almost normal, overweight, 28 BMI, and he is on 1 gram metformin twice a day with amlodipine, telmisartan for hypertension management, and for lipids, rosuvastatin, 10 milligrams once a day. What is his medical history? His history of hypertension and diabetes, 2 years diagnosis of diabetes. Metformin initially started with 500 milligram twice a day and gradually increased to 1000 milligram twice a day, but still his HbA1c was 8.3. Current laboratory diagnosis, 8.6 HbA1c, 165 fasting and 280 postprandial blood sugar. LDL-C is high, 120, and EGFR fortunately is normal. So what should we do at this point of time? So whether we increase one drug at a time and then see and then gradually increase the third or fourth drugs, let us see what are the challenges in front of us. We have the challenges. Physician related means there are certain physicians we are free to target. They are very aggressive. But some medication related means we start with one agent, two agents, and gradually three agents. And patients actually want the good diabetes control. So let us see the meta-analysis. And this is the use of fixed dose combination in those things. And what this meta-analysis suggests to us, that if the patient is on the fixed dose combination of two drugs, then the adherence is much, much better. The compliance is better as compared to the patient who are having only two drugs or three drugs, but different times. What guidelines suggest to us? The guidelines suggest to us, and this is the recent 2020 guidelines, and clearly said that since the absolute effectiveness of most of the oral medications rarely exceed 1% reduction HbA1c. So we have to have the initial combination of the drugs, at least 2 or 3 drugs. So what is the guidelines? Here, if you see, this is the recent ADA 2020, they clearly said if you have a atherosclerotic cardiovascular disease, CKD, or heart failure. So if you have a high risk patient, don't wait for one drug or two drugs. Start with SGLT2 inhibitors, GLP-1 receptor agonists, and even third drug like DPP-4 inhibitors. So if you have a heart failure or CKD predominates, of course, SGLT2 inhibitors and DPP-4 inhibitors. So this is what the ADA 2020, the overall meaning of these guidelines means you have to start aggressively right from the beginning so as to achieve the glycosylated hemoglobin. We know this defrontos octet. There are so many causes for hyperglycemia. So if we use like metformin, so metformin attack only at the liver and reduces the hepatic glucose output. What the addition of sulfonylurea, DPP-4 inhibitors, and other drugs, we have to correct so many other hyperglycemia causes. Like as if you use the sulfonylureas, correct only the beta cells secretion. If you go with the DPP-4 inhibitors, of course, it attacks so many hyperglycemia causes. Start from the liver, the glucagon increase, the gut, and the glucose uptake, and also and theoretically insulin secretion is also affected by DPP. What we'll achieve with SGLT2 inhibitors? Clearly reduce the glucose uptake here, increase glucose reabsorption at the SGLT2 in the kidney, and of course indirectly insulin secretion also increased. So dear friends, if you see here so many hyperglycemia causes, simply giving one metformin does not mean that we are attacking most of the causes for hyperglycemia. So if we use DPP-4 inhibitors and SGLT2 inhibitors, probably we attack most of the hyperglycemia causes. So what is the beauty of complementary action of SGLT2 inhibitors and DPP-4 inhibitors? If you see here, SGLT2 inhibitors merely increases glycosuria, decreases the glucotoxicity, indirectly also affects the beta cell sensitivity and increases the glucagon at the pancreas level, and also having little dual pancreatic effects. What the DPP-4 inhibitor does, same indirect pancreatic effects and dual pancreatic effects like increasing insulin secretion and reducing glucagon, while on intestine, the gut effect, the incretin effect, increases GLP-1, decreases the GIP. Ultimately, the whole gamut of complementary actions of SGLT2 inhibitors and DPP-4 inhibitors reduces weight in the patient, reduces systolic blood pressure, and here, because of the DPP-4, it is the weight neutrality. The overall effect is the reducing the hyperglycemia, and that is to the tune of targeting the HbA1c. So there are so many studies published. The additive effects of AMPA and metformin, AMPA and LINA, if you see the green bar here, it attacks most of the postprandial blood sugar. And ultimately, what the clinical concerns of our patient, like we have seen our garden variety of patient, like HbA1c was 8.6. So if we start with the drugs, and if you see here how we can have the individualized things here, I think most of the clinicians know about this thing, how we start any drug in a patient. So we have to see the risk involved, right? Whether the patient duration of diabetes is recent or little later, life expectancy is long or it is short, important comorbidities present like kidney disease, heart disease, and other comorbid conditions, established vascular complications. A patient is already having macrovascular complications already there. Then the patient's preference also we have to see, and the resource constraints. So these are the things we know about this thing. So how to start the optimization of these two drugs, empagliflozin and linagliptin, SGLT2 inhibitors and lina. And if you see here, whether the patient is a low baseline, means less HbA1c around 8%, and if the patient is having more than 9%, the action is still there. If you see here, even at the low baseline HbA1c, the patients achieve more than 1% HbA1c reduction. If high baseline HbA1c, patients have the more than 1.6 to 1.8% HbA1c reduction, which is very unprecedented and something very good for the patient. So for optimization of combination of these two drugs, like even in drug-naive patient, and if the patient is already on the metformin background, see the beautiful effect of AMPA-LINA combination. This is the AMPA-LINA combination here, and that gives us the beautiful HbA1c reduction. So optimization with both the drugs are there very high efficacy, and what we are achieving out of these combination, that hypoglycemia risk is minimal, and overall it is the weight reduction. So that means now we have 2 or 3 concerns: genital tract infection, and fortunately the combination of AMPA-LINA has the less genital infection, and that cause may be little different. Similarly, genital infection, if you see here, most of the meta-analysis, most of the study suggests that if you have a combination of AMPA and LINA, the genital tract infection is little less as compared if you are using the SGLT2 inhibitors alone. Similarly, now we have concerns with the body weight reduction. See here, the AMPA-LINA combination as a weight reduction to the tune of 3 kilograms. Systolic blood pressure reduction again to the tune of around 3.6 millimeter of mercury, and diastolic of course doesn't matter here, and there is no effect on the diastolic blood pressure. So addressing our patient here, and if we want to achieve the metabolic control here, then we have to have the 2 or 3 drugs here to the combination. And if here on further investigation the patient is already having left ventricular hypertrophy and there is a 60% LVEF, and of course the patient is already having the microalbuminuria. So is this the problem, that patient is already having a subclinical cardiovascular disease and microalbuminuria already starting? Yes, the ESCC and AHA clearly suggest that these patients have the structural heart disease but without the sign and symptoms of heart failure, means the patient is already in the incipient heart failure thing. So this is this a problem? Yes. So let us see the overall patient's care here, and if I can't go into the details because of the paucity of time, but if you see here, it is a metabolic cardiorenal continuum, means the patient is already having diabetes, obesity, hypertension, and it goes to the structural heart disease, LVH, myocardial infarction, remodeling occurs, ventricular dilation, cognitive dysfunctions there, then the patient is already heart failure and is heart disease and ultimately lead to cardiovascular death. On another side, this is the endothelial dysfunction, patient goes in microalbuminuria, macroproteinuria, nephrotic proteinuria, and ultimately end-stage renal disease, means these patients are in a continuum of increasing the cardiorenal complication. So let us start right from the beginning that we have to prevent the control and risk factors. We have to regress if patient is already progressed to the remodeling and the myocardial infarction, and then you have to regress at this point of time, and ultimately even if they reach to the end stage disease, we have to retard if possible. So we have to attack the hypertension, diabetes, obesity, subclinical cardiovascular disease, microalbuminuria, and ultimately we have to prevent that patients should not go into the end stage renal disease. And if you see here, we are the few SGLT2 inhibitors, and I think from our point of view at present, SGLT2 inhibitors and GLP-1 receptor agonists are only the 2 drugs which can address the cardiovascular outcome of the patient, that is to the tune of around 30 to 40% depending on different SGLT2 inhibitors. And if you see here, different combination of different comparison of AMPA, CANAC, DAPA, and ATU, and if you see here, all the 4 whether the hospitalization for heart failure, cardiovascular death, 3-point MACE, and renal outcome, if you see here in the AMPA, that also addresses all the cardiovascular outcome risks. So let us see the AMPA heart study, which is recently published, and clearly suggests to us that not only addresses the cardiovascular risk reduction, but left ventricular mass is also reduced by the AMPA in the AMPA heart study. And even the patient is already having left ventricular ejection fraction less than 40%, and even eGFR is less. Even Emperor study clearly showed us that the empagliflozin, I think, is the best drug to reduce the most of the cardiovascular risk factors. So let us see if you see here, beautiful graphs here, if patient is already having albuminuria, and if there is a 15% relative risk reduction in urinary albumin creatinine ratio. What else we want from any drug? Not only the cardiovascular risk reduction, but also reduces the microalbuminuria. So my dear friends, if we use the combination of these 2 drugs, whether the 3-point MACE, cardiovascular mortality, hospitalization for heart failure, and even the renal outcomes, if you see here in AMPA, it reduces all the cardiorenal outcome as compared to any other drug. Even ESC/ESD in 2019 guidelines clearly suggest that if a patient is already having the risk for atherosclerotic cardiovascular disease, start right from the beginning right from the day of diagnosis, SGLT2 inhibitors. And this is a class 1A recommendation, dear friends. And not only this, even the SGLT2 inhibitors are recommended in the diabetes to reduce the heart failure risk. It is also to be recommendations by this thing. So we have already seen the cardiorenal continuum here. So there are certain pleiotropic effects. If we use a combination of LINA and EMPA, we can reduce up to 1.8% HbA1c reduction. We can actually address the cardiovascular remodeling. MACE and heart failure benefits are already been seen, and even the albuminuria benefits have been seen by LINA in the Carmelina study. So overall, if you see here, the patients, if on two drugs, SGLT2 inhibitors and DPP4 inhibitors, gives a significant effect. And if you see our patients, we have started the EMPA-LINA combination, and there is a robust HbA1c reduction with minimal risk of hypoglycemia. That is the beautiful thing with this combination. Weight reduction is already there, blood pressure reduction is there, and overall, if I can summarize the optimization benefit of EMPA-LINA, then if you see here, it addresses the multiple pathophysiological mechanisms. So if you are using two drugs at a time, compliance, other than the compliance, the multiple pathological defects have been corrected by these two drugs. There is a robust HbA1c reduction in the weight, blood pressure, albuminuria, vascular functions are improved, and not only there is evidence for cardiovascular, heart failure, renal outcomes are being improved, and there is a proven mortality benefit in the empagliflozin have been seen in the class 1 recommendation. And both EMPA and LINA recommendation in the patient at risk of heart failure and type 2 diabetes, I think one of the best combination drugs at present for the management of type 2 diabetes. Dear friends, it is safe, cost effective, convenient for a once daily dosing, and what else we need from our patients. Thank you very much, and I'm available for the questions.
Thank you, Arvind. So nicely presented this combination, how we can use it, and with a clinical case presentation, this has become even more important. I think this is one patient which we see practically every day in our clinical practice. And absolutely. I think those must have really benefited with the way you have presented the benefits and the advantages of using this combination right from the beginning. If there are any quick questions, Dr. Narsingh Mathur, can we have one or two quick questions if they are there? Because we're already short of time. Dr. Narsingh Mathur, can we have some questions if they are there?
I think Dr. Narsingh Mathur is very silent right from the beginning.
You can unmute yourself and you can ask if you want. Anyway, just one question, Arvind.
Sir,
you said that there are less chances of UTI when we use a combination of DP4 inhibitor and an SGLT2 inhibitor. So
right.
The audience would like to know what exactly is a single reason why there should be less UTI when SGLT2 is being used here.
Exact mechanism is not known, Dr. Minavar, but it is being said that whenever we are using DPP4 inhibitors in a combination with the SGLT2 inhibitors, the DPP4 inhibitors are already there in the urinary tract, and they also inhibit the DPP4 enzymes in the urinary tract also, not the DPP4, maybe DPP8 and DPP9 here, and that's why the mucosal resistance is increased by using the DPP4 inhibitors. Hence, there is a reduction in the urinary tract infection and genitourinary infection when we are using in combination with DPP4 inhibitors and SGLT2. SGLT2, of course, increases the glucosuria, and that's why there is increased chance of fungal infection. And because of this mucosal thing, the DPP4 inhibitors protect it from the fungal infection. So probably this is the real mechanism, maybe this mechanism responsible for less UTI and less GTI in a patient when we are using in combination.
Truly said, it is clinically also found that in patients where we are using a combination, there is definitely a less percentage getting a urinary. So thank you very much, Arvind. If there are no questions, we proceed to the other session. It was a wonderful session, and thank you very much for sparing time for us. Thank you very much.